Okay, this is a talk that I've done a couple times, and I always like to revise my talks, but it's called The Battle of Next Generation Therapies. This was given at the 2026 Canadian Retina Society meeting in Toronto, Canada. I was actually honored to be named the Mila Oh to give this lecture in honor of Mila Oh. I didn't have a chance to know Mila, but from everything that I read about her, she sounds like an amazing person who really lived life to the fullest. And I think that this talk was felt to be best to honor her because she battled breast cancer until the very end. She passed away at the age of 41 and was a real fighter, but also was a really infectious personality. And I feel like this is a talk that, in all great respect to her, is about the battle we have against macular degeneration and diabetic macular edema. And it's a fun talk that I really like to give. So it's in her honor. These are my disclosures. So when we look at anti-VEGF therapies, and these are studies over the last decade and a half looking at or 2 decades now, looking at the treatments that we've had approved for macular degeneration, diabetic macular edema, and macular edema from venous occlusive disease, we can see one thing in common: unprecedented visual acuity gains. But they all look very similar. Our treatments all work about the same way. And this is great. This is a game changer for our patients, certainly. But we have a problem. And the problem is that we have increasing rates of macular degeneration as the baby boomers age, and people live longer. And we have increasing rates of diabetic retinopathy and diabetic macular edema. And so we have a tremendous treatment burden. And in fact, when you ask retina specialists, and this is the 2020 PATH survey, but surprisingly over the last 6 years, this hasn't changed. When you ask retina specialists, what do we need? Most, they say we need something that can reduce treatment burden or deliver long-acting or sustained delivery. And these really are one and the same. 2/3 or 3/4 of retina specialists say that we need something that can provide the same type of treatments and outcomes that we see in these clinical studies, but reduce the number of times that patients have to come to see us and have to get needles placed in their eye. And we know that with first-generation therapies, Lucentis, Avastin, Eylea, that there is a correlation between a number of injections and visual acuity. And for years, we saw a trend towards patients getting undertreated and not achieving the kind of outcomes that they would see in clinical studies. I think we're doing a better job with that now, but it's still a potential risk. So when we look at the next generation of therapies, second-generation therapies, specifically Vabysmo and aflibercept or Eylea HD or 8 milligrams, we can see in the Tenai and Lucerne study, Yosemite and Rhine, Pulsar and Photon, that we do see increased rates of Q12 and Q16 week dosing, which is not the holy grail, but it's a definite improvement over where we were with the first-generation therapies. But we're still left asking which is the better of the two drugs. And I'll just tell you right now up front, I'm not going to tell you which of these two is better. I think this is something that you have to figure out clinically for your patients. And it involves switching patients, moving from one drug to the other drug, seeing which dries out more effectively for each individual patient and which has the greatest durability. But we can certainly garner a lot of interest by looking at these two treatments in a variety of different ways. The first way is to look at the molecules. Now, with first-generation therapies, we can see things like binding, dissociation constants, half-life, targets, dosing, molar equivalents, other things that can give us some ideas to potential benefits of one versus the other. But with the second-generation therapies, particularly faricimab and aflibercept 8 milligrams, it really comes down to a bispecific molecule that binds VEGF and Ang2 with each of the FABs. And our familiar VEGF trap molecule, albeit at a higher dose. Now, you'll notice faricimab is not just a bispecific, but it's actually a higher molar dosage version of ranibizumab. And I do think there's some benefits to just simply having a higher dose of this excellent anti-VEGF. So the first question really has to be, does Ang2 really work? Now, we know that the Ang1 activation of the Tie2 pathway is very important in vascular homeostasis and endothelial cell health, pericyte stability, and whatnot. And when you have a breakdown of those things by inhibition of the Tie2 signal or decreased Tie2 signaling, you get this pathologic vascular response that leads to formation of new, immature, leaky blood vessels. And we see that Ang2 levels are upregulated in disease states, most in RVO and diabetic retinopathy, but also in AMD. And in a very similar fashion to VEGF, except if you'll notice the y-axis, instead of being in the nanogram per milliliter levels that we see VEGF upregulated, it's in the picogram per milliliter levels. This is 1,000-fold lower than what we see for Ang2 elevation than VEGF. Now, we do see that faricimab blocks Ang2 on a much more sustained level. It'll block Ang2 for 3 or 4 months after a single dose. So that would make some sense as far as that goes. But it's interesting that it's a much lower level of Ang2 that's upregulated in these disease states. Now, when we really think about angiopoietin-2 and its effects, I think it's interesting to look at the development and discovery of that Tie2 pathway in Ang2. And if you'll notice here, these very early papers in the early 2000s all have one common author, George Yancopoulos. And George Yancopoulos is an MD PhD. He happens to be the president and chief scientific officer of Regeneron. Regeneron developed an Ang2 inhibitor. It's called nesvacumab. And they looked at it in both AMD and diabetic macular edema through the Ruby and the Onyx studies. And it's very interesting. I have not talked to George about this, but I've heard that George said, even before they went in to investigate, hey, I don't believe this is going to work. And the reason I don't think it's going to be as effective as we would hope it would be is because these disease states actually have an inadequately or an insufficient amount of Ang1. See, Ang2 binds the Tie2 receptor and prevents Ang1 activation of that pathway. But if you have a deficiency of Ang1, it doesn't matter if you have a lot of Ang2 around or not, because you don't have any Ang1 to activate the pathway. And in fact, Merck and Roche are both looking at Tie2 activators and investigating Tie2 activators to be a potential improvement on our current therapies. Regeneron did study a co-formulation of nesvacumab and aflibercept, and they didn't show any improvements in visual acuity with these treatments. They did show some improvements in retinal thickening and drying of the retina with their Ang2 inhibitor. But after these phase 2 studies, they decided not to pursue the Ang2 pathway or Ang2 inhibition. So then the next question has to be, does higher dose work? And the concept behind higher dose is pretty simple. You're putting more molecules into the eye, and that should give you greater durability of a drug. So if you, for example, with aflibercept 8 milligrams, you're adding 4 times the dose, that's giving you 2 additional half-lives. And a normal patient half-life is traditionally about 9 to 11 days, we think, of aflibercept. And so you're adding 2 additional half-lives. Now, Now, there is some evidence to suggest that maybe there's an additional 34% slowing of ocular clearance with the formulation of aflibercept 8 milligrams. So the way I like to think about it is if a patient has a normal 9 to 11-day half-life, and half-life can vary patient to patient. You might have people who have a 3 to 4-day half-life, or people who have a 15 to 18-day half-life of the drug in their eye, but the average is about 9 to 11 days. So if you get 2 additional half-lives plus an additional third, you're basically going to say that you're going to have about another 3 to 4 weeks of durability in a patient that's on 8 milligrams versus the 2 milligrams of our standard dose. Now, higher dose has been looked at, and it was looked at long ago by Genentech in the Harbor study, where they looked at a 4-fold higher increase dose of ranibizumab, and they really didn't show any difference in durability or treatment. And the interesting thing about Harbor study is these patients that were treated PRN were treated very aggressively. If they had any fluid whatsoever, they were retreated, and we can see no difference between the 0.5 milligram of ranibizumab versus the 2 milligrams. They looked at it in DME and actually showed that it was no more effective at drying macular edema than the 0.5 milligram dose, and that was in the READ 3 study. And what I like to do is compare these two things head to head. So here's an example of a patient that was getting monthly faricimab. We can still see a little bit of persistent fluid, and I gave her 8 milligrams of aflibercept and brought her back in a month, and she was drier. Now, was there any visual acuity difference between these two visits? No, because her foveal center was relatively dry after both of them, but it does show anatomically there's a little bit of an improvement with the 8 milligrams. Stay tuned, because I'm going to show you a follow-up to this case that made me take this patient back to faricimab. So when we look at the higher dose, we have to ask ourselves, we have 6 milligrams of faricimab, and that's at a 50 microliter dose. The aflibercept 8 milligrams, to get the full 8 milligrams, you have to give a 70 microliter dose. What would happen if we gave a higher dose of faricimab? If you do see a difference in the two, is giving an additional 20 microliters of faricimab going to actually give you greater durability? It probably will. It's just not the labeled indication. So we do have a difference in volume between these two drugs, with the 8 milligrams of aflibercept requiring some additional volume to get that full 8 milligrams. And so I think, what would happen if we gave a higher dose of that faricimab? Would we see a more prolonged effect? We can look at the study design, and there's positives and negatives to the study designs in both of these cases. If we look at the Tenai and Lucerne studies, the AMD studies for Vabysmo, the beef I have with these studies is after the first 4 initial injections of Vabysmo given monthly, they assessed disease activity, and they slotted patients in to receive injections either 8 weeks or 12 weeks or 16 weeks based off their response to those first 4 injections. I don't love that. I love a study that's kind of just straight up at entry. You're going to get loading doses, and then you're going to go to 2 months or 3 months or 4 month injections, and we're going to figure out if you need to be rescued sooner or later. Now, my beef with the Pulsar study is that there's this combination of both loss of visual acuity and increased central subfield thickness or new macular hemorrhage, whereas in Tenai and Lucerne, if you had any one of these things, loss of vision, increase in central subfield thickness, or new macular hemorrhage, you'd have to be retreated more frequently. And you can see, if you applied those Pulsar criteria to patients in Tenai and Lucerne, there would be a significant number that would make it out to 12 weeks. This is a cross-trial comparison and is a little weird and not quite true, but still, I like to see studies that I can kind of align as far as their retreatment criteria when trying to compare cross trials, and there is a bit of a limitation with that and combination. One of the things that we can see is speed of drying. Now, once again, this is compared to 2 milligram of aflibercept, but if you look at DME, there is definitely faricimab or Vabysmo definitely dries quicker. And you can see here some differences in initial drying in OCTs and in fluorescein leakage in the macular area. And you really see this when we look at this Kaplan-Meier curve as far as the first absence of intraretinal fluid, which is months earlier with faricimab compared to aflibercept 2 milligrams every other month. So for a patient that has really bad bilateral diabetic macular edema, I'll tend to choose faricimab as my treatment of choice, and I'll give them monthly injections until they're dry. And here we can see a pretty impressive response to a patient that came in legally blind and now has the ability to drive. We don't see a major difference in this cumulative incidence of first absence of intraretinal subretinal fluid in our patients treated with wet AMD. And that's because they do show an absence of fluid much earlier. Here we can see a difference of about 1 month with the faricimab-treated patients being drier at week 8 and the aflibercept-treated patients being drier at week 12. We see the same thing, actually, if you look at the Pulsar study. We can see that those patients treated with 8 milligrams do achieve a completely dry retina sooner than those patients treated with 2 milligrams. What about in tough lesions? Now, data-wise, we do know that faricimab is more likely to result in a reduction in PED volume and improvement in PEDs. We have yet to see the data from the Pulsar study about PEDs, and I look forward to seeing that. But this improvement in PED height and volume does lead me to choose faricimab for a lot of my bigger PEDs. Here we can see a patient that came in. They're receiving monthly aflibercept. We treat this patient. They still have some subretinal fluid. in that right eye. So we switched them over to faricimab, and I was impressed in this eye that we saw the resolution of that subretinal fluid. We continue to treat. I didn't expect the PED to get much better, but we see some continued improvement in the PED, and I was really surprised by this last visit where we saw further reduction in the PED and actually improvement to 20/50 vision in this patient that has a definite RPE rip. What about safety? Well, safety-wise, one of the biggest things that helps us as far as safety is not having to draw the medicine up. And right now, as of April 2026, we only have a prefilled syringe for faricimab. We don't have it yet for aflibercept 8 milligrams. Internationally, they do have a prefilled syringe for the aflibercept 8 milligrams. One of the other things is immunogenicity. And if you look at the difference in molecules, and this is a paper actually out of the dermatology literature, but it really shows this quite nicely. When you think about neutralizing anti-drug antibodies, a humanized antibody can develop immunogenic anti-drug antibodies to the binding site of the FAB region, which can make the antibody less functional, and you can see a waning of the response. So we might have somebody on faricimab that's receiving injections every 8 weeks and looks good, and all of a sudden you see them back at 8 weeks and they have new fluid, and you have to go back to every 5 or 6 weeks to get them dry. Whereas patients with the fully humanized fusion protein of aflibercept can get anti-drug antibodies, but they tend not to be directed towards the binding sites that binds the VEGF. The one concern, and this is more of a concern internationally, but it certainly should be on our mind, is there is a higher volume of the aflibercept 8 milligrams, and does that 70 microliter volume increase the risk of glaucoma? We've had geographic atrophy drugs, and the geographic atrophy drugs actually can increase, in my mind, the glaucomatous progression in patients who have glaucoma or risk for glaucoma, and I tend to avoid them in those patients. So far, I have not seen any sustained elevated IOPs in patients with the 70 microliter injection of aflibercept. And then last but not least, when we have these two very comparable molecules, we have to think about cost. And in the U.S., at launch, the cost for faricimab was right around $2,200. For aflibercept 8 milligrams, it was just over $2,600. So you have to ask yourself, is the value there to justify an additional $400 plus for the aflibercept 8 milligrams? The labeling was a concern in the U.S. up until recently, and the concern was that we could only give 3 initial monthly injections, and then we had to go every 7 weeks thereafter. This is based off the pulsar and the photon studies where they had 3 initial injections and then went 3 or 4 months, and they could be rescued or treated more frequently, but only every 8 weeks, not every month. And here we can see, when you look at the pulsar study, about 6% of patients with wet AMD would need to be treated more often if you looked at the treatment or reduction in treatment criteria. In the photon study, it was 1.5%. Back to that original patient. Here she was 1 month after the faricimab, a little more leakage, 1 month after the 8 milligrams, but I could not get her out to 7 weeks. Here we can see her first visit after that initial 8 milligrams. It's 5 weeks after a 2 milligram, 9 weeks after the 8 milligrams, and her fluid is back and much worse. So because she couldn't go 7 weeks or couldn't maintain a dry retina at 7 weeks, we had to reduce her, or we had to return her to faricimab and treat her with faricimab monthly. And we switched her back over to Eylea 2 milligrams monthly thereafter. Finally, we were able to get her on 8 milligrams and use it more often because of this change in the labeling. So labeling change just occurred, and it was due to a Regeneron-sponsored monthly treatment study in the U.S. that showed that certainly some patients benefited from monthly injections, and now we can treat these patients every month if they need it, if they can't be extended out. So just in summary, second-generation therapies are an advancement. Both faricimab and aflibercept do allow for greater durability. They don't routinely last 3 to 4 months in our tougher-to-treat patients. There's no clear-cut winner. I use both for different indications and different types of patients. And I think if we're looking forward to more durable therapies, we might have to look forward to TKI and gene therapy advancements, looking at other pathways, looking at Ang1 simulators or Tie2 activators, the WNT pathway and whatnot, to see if we can have any greater improvements beyond these next generation therapies. Once again, it was a really great honor to give this lecture named after Dr. Oh, who certainly improved the lives of her patients, her families, and her friends. And I do appreciate the Canadian Retina Society asking me to give this. Thank you so much.